Welcome to the latest edition of the Journal of the American College of Radiology Journal Club. I am the moderator for this evening, Associate Editor of Digital Media for the JACR, Amy Patel. And I am just so excited to have this journal club this evening with our three esteemed guests and authors of a very interesting piece in the Journal of the American College of Radiology. The topic today we are tackling is achieving educational excellence in an era of accelerating healthcare consolidation. Certainly a very hot topic right now in the field of radiology. But first, before we dive into questions and the discussion, I want our panelists to introduce themselves. So first, Dr. Wheeler.
Hey, thank you so much, Dr. Patel, for having us, and it's great to be here. So I am currently a pediatric neuroradiology fellow at Emory, and just recently finished up an adult neuroradiology fellowship here as well. So at the final stages of training, and yeah, it's great so far.
Great. Well, so wonderful to have you. Thanks for being here. Dr. Taylor?
Hey, Amy, thank you so much for having us. I'm Charlotte Taylor. I serve as the Diagnostic Radiology Residency Program Director at the University of Mississippi Medical Center, also serve as the Vice Chair of Education for our department.
Awesome. Thank you for being here today. And he needs no introduction, but Dr. Duszak.
Hey, Amy, thanks for having me. Thanks, everyone, for being here this evening. Rich Duszak, I'm currently chair of radiology at the University of Mississippi Medical Center. I spent the first 18 years of my career in private practice, and even in private practices and in academic practices, I've always been in a program that's had a residency. So the issue here at hand is of particular interest to me. Just a little piece of trivia, seeing the JACR sponsoring this. I actually have been a member of the editorial board of the JACR since it was founded in 2004. So it's really great to see the journal leaning into digital media, and congratulations to you, Amy, for running the show here.
Thank you. And thank you for being a part of this. Yes, Dr. Duszak has made immense contributions to the journal and to the editorial board, and I was sad to see him cycle off a few years ago, but he wears many hats. So, so let's go ahead and dive into the discussion. So my first question is for Dr. Wheeler. So how did this manuscript come about? I'm very interested to know about this. And, why did you think it was important for you to touch upon this subject with this team?
Yeah, absolutely. So, I think everyone can feel the acceleration of change in the past few years, consolidations included. We've seen hospitals close, we've seen residency programs shut down, big practice mergers. And so I think as things accelerate, it just becomes even more essential to take a stop for a moment and really just get a pulse on kind of the state of things, And so I think part of that is just taking stock of the educational mission and, any potential new gaps. So I think we came together and just realized, there were some wins across the board already, and just wanted to share those tips with others to see, if anyone else could benefit. I think we really had the dream team here. You have Dr. Duszak, a department chair and recent vice chair. We've got Dr. Taylor, who's been our residency program director and now vice chair. And then, myself just kind of recently going through residency and fellowship. I think we just kind of bring a range of perspectives to the table, and also just kind of variety of institutional experiences too. And so just wanted to kind of look at this from different angles and, see what has worked, what hasn't. And so, we see this article not as a prescription for success, but rather just sharing tips, to see, what you can consider implementing.
Yes. And I'm sure, Dr. Duszak, you were, probably, if I had to guess, that you're itching to maybe write something of this caliber because you've seen a lot, I would suspect, in the years of clinical practice and leadership and just all the changes you've seen in healthcare.
Yeah, I haven't been around as long as Redkin, but I have been around for a while in radiology, finishing my residency in 1994, fellowship in 1995, and a lot has changed. And there have been great things over my career with how radiology trains its next generation. But we have entered a period with some very big disruptors, if you will, in the marketplace. Our programs, our institutions are getting bigger and bigger. It's led to depersonalization. It's led to multi-centricity of where our trainees are. It's led to less of the one-to-one relationships that we've traditionally had between our residents and our faculty. And so we have to think about creative ways of overcoming that. We've got immense challenges at the faculty level now for RVU productivity, because that's just, that's how healthcare is delivered right now. I don't think it's the right way, but that's clearly where we're going, that's the big priority coming from our health systems, whether they're private or academic. And it's not just isolated to radiology as well. I think a lot of people are saying, oh, radiology, ACR needs to fix this. This is broad, it's systemic, it's a secular trend that all of our colleagues in other departments are dealing with as well. And so, like a lot of other places, we've been, trying to be nimble, trying to be creative, and I think that's ultimately how we're all going to find our way out of this. To Dr. Wheeler's point earlier, our article is not intended to be prescriptive. This is sort of stuff we've done, some ideas we have. Some people may disagree and say, I've got better ideas. And quite honestly, that would be great if we could catalyze those types of conversations. But it really is to get some of the conversation going and to particularly try to fight off some of the learned helplessness that's out there of, oh, the world's changing, I don't know what I can do. Well, there's some things you can try.
Yeah. And, Dr. Taylor, I'd love to hear your insights of why you wanted to be a part of this.
Absolutely. I think this is a very hot topic among educators, among program directors that we discuss, getting together in the APDR through the AAR meetings. And really a frustration that many educators have is that there's a lot of emphasis on productivity, but it's the reactions and the feelings of program directors across the country seems to be not one of just complete helplessness. I think people are getting creative and really looking at it. We wanted to look at this as how to allocate resources and look at educators and time and the efforts that we put towards our educational programs as a resource limited system. And so if you look at it in that way, that's what the article is trying to address, not being unrealistic, saying, well, if everyone just loves educating more, then we'll just all do great. Like really looking at it from where do you put the people for the best yield, for where is the most important places? Who can you bring in to augment our educational mission? So really looking at it in a practical standpoint is what we wanted to do. And these ideas are not just from our institution. This is from sourcing, talking to other program directors and how they're managing these high clinical volumes and the tendency towards remote workforce and really getting creative about what's actually needed to educate residents in this environment.
So, Dr. Wheeler, what are the sort of main points or tips that, let's say somebody is tuning in and possibly hasn't had time to peruse your piece. What would you, convey in terms of the biggest, salient points or tips?
Yeah, for sure. I think the meat and potatoes version of it is, radiology systems are getting bigger and they're being pressurized. Education is taking a back seat to other priorities, unfortunately. And so, clinical productivity among the top of those. So some strategies that we suggest to overcome that are, clarify daily assignments to offload clinical volume. And that way you can really protect time and even provide incentives to dedicated teachers. I think also, really concentrate in-person efforts on junior residents and other areas of need that you identify. And also speaking to Dr. Taylor's point about, resource allocation, really bringing in resources from beyond just radiology attendings, and also even collaborating beyond your local department. So take advantage of those. And then lastly, be proactive about hiring and recruiting with strategic training pathways. And I think all of those really complement one another and sort of provide this kind of cohesive front to tackle this. So there really are, I think, a range of action steps you can take to catalyze learning in the day-to-day and also in the long term.
Dr. Duszak, you have anything to add?
Yeah, a few thoughts. I spent a lot of my academic career working with economists. So, I've always learned from them this sort of pragmatic approach to when you have a fixed amount of resources, what do you do with it? One has told me, if you've got a fixed amount of resources, you can do anything, but you can't do everything. And so, we do need to, back to Charlotte's point, Austin's point, we need to be prioritizing. Is education important? The answer, of course, is yes. We have to create the next generation of radiologists. And if so, how do we do it? How do we allocate those resources? So, some of it, I think, from a point of view of the take-home points, at least for me, is, we did highlight, for example, some of the point system that's been used in our department, which actually came from work that I was involved in the leadership in Emory's department. And, I think they've pioneered it as well, to be able to say what is important to us as an organization. And, the way you really, I think, bring down the message, every place has got, oh, here's our values, here's our strategic plans and this and that. But how do you reward people? How do you incentivize people? That's how you really say what's important. Because if you say, oh, we all want to do this, but you don't get paid for it, or you don't get time off for it, then it's not really important. So, we've worked hard in our department. Admittedly, you have to work within the structure of a compensation plan, some other things, to be able to, give people points, if you will, for giving resident conferences, for our teaching awards and things like that, and prioritizing it so that people say, this is important to do. My leaders are saying this is important for us to do. And again, you can do anything, but but you can't do everything. But what you choose to do really depends upon how your organization prioritizes, and you've got to make it a priority and figure out a way to do that.
Yeah. Dr. Taylor, anything to add?
Yeah, I would say just to add to Rich's point is incentivizing education and the research mission is not only part of what we do in an academic center, but it's vital to the accreditation of residency programs. And if we don't have those portions of our mission, we can't have an accredited residency program. So it's practically we need to be doing this, and having this point system is very useful, and it's a step in the right direction. While it's not a large amount of our compensation plan, even a small amount of reward goes a long way for education, for research, and for the clinical mission of things like tumor boards, which were previously uncompensated in our department. And so rewarding the people who were doing the disproportionate amount of those different mission areas is very important and valued. Another thing I would add that I think is great about the system that we have is that each category is capped at a number of points, and therefore you can't just blow all your RVUs out the roof and be very clinically productive and get all of the points. You can only go up to a certain ceiling, and in order to get more points, you have to broaden out your involvement. And I think that's been really successful, to have the full breadth of a mission rather than just one side of it.
Yes, I think that is amazing. Do you know, any of you, how many programs you think are utilizing a kind of similar structure or system? Just even anecdotally talking to other PDs or chairs. Do you have any idea?
I think some people are dabbling in it. I don't think we're the only department. I think there are places who are talking about using educational value units. I don't have a tangible number, but it is on the forefront of people's mind, because how else do you quantify education?
I think it's increasing, Amy. I get a number of calls from chairs across the country, faculty across the country saying, hey, I heard you guys are doing this. What do you do? I think one of the rate limiting steps for this is having an enabling faculty compensation plan that allows the department leadership to be able to prioritize things. You know, I'm fortunate to be chair of a department in a system that does give the chair up to 10% of total clinical dollars of discretion as to what we can do. Now, we use, to Charlotte's point, far less than that. You know, when I came into the department about 3.5 years ago and even brought up the concept of, you know, we're going to have performance metrics, but no, we've never had these before. We don't know what to do with them as well. So we wound up having a pretty small piece. It's only 2 or 3% of folks' comp, but you know, it's a little trophy. And the other piece as well, I'll call out with that, give Dr. Taylor some credit because she helped push this as well with our chief residents, is we've also started giving out some awards. You know, we give out a Skelly Award, which is a little, you know, sort of pseudo gold-plated skeleton that I think Charlotte bought at the dollar store or something. Yeah, they're cute. Every month, the residents, excuse me, give a Skelly Award out to the best faculty lecturer of the month. So it's created some really nice competition. You know, people really want to perform, and you know, it's some people have really risen up as a result of it. And for, I don't know what the Skellies cost, $5 or $6 or $10 maybe, but we've gotten really good return on investment. So my point with that, back to your question, is I'm not sure a lot of people have as structured a plan as we have, but people are doing creative things.
Yeah. And I wonder that having these things like, awards and competition might help in terms of just the morale of a department, especially, it can get tough, right? With getting killed on the list, and you're trying to keep up your positive attitude and teaching residents, and it can be challenging. So I'm sure that also helps with morale. Yeah. Great. Well, before I head into the next question, for those of you attending, please, if you have any questions, please add that to the comment section, and we'll be sure to address them. And we also have, we're live on X, so hopefully some people can also share some questions on X, and we're monitoring that too. So, all right. So my next question, so Dr. Taylor is a program director, and I just feel like even in the years of practice I've had, and my friends who are PDs across the country, and in the residency program I'm affiliated with, and the demands are just increasing, and it's I mean, let's be honest, I'm going to be very honest, it seems like it's a thankless position at times, and the amount you put in, you don't necessarily get all that that you put in. And so I just really appreciate people like you that are PDs. I think it's a tough climate to be a PD. So as a program director, are you alarmed with the implications of resident education suffering due to this like rapidly changing healthcare environment? And it seems like maybe you've discussed this with some other PDs. You mentioned APDR, but what are your thoughts? What are their thoughts? I'm just so interested to know that sort of the collective sentiments regarding this.
Yeah. Well, thank you, Amy, for your sympathy, I guess, for my position. It can seem like it's a thankless job, but I have really great residents, and I have a great chair who supports me and gives me the time that I need and to do the position. And I think a lot of burnout among PDs actually comes from the lack of time allocated to, non-clinical time to do the position. And I think that's a lot of what's helped me be successful in my role, is that I do get that time, and it's a lot of work. I think the sentiment among program directors is it's kind of a mixed bag, but I've heard anything from, I don't have the support I need to even implement change. When the clinical volumes go up, people just don't teach. I have others who say it's less of a problem. It's really a mixed bag. And while I'm a little concerned about, losing the way it was, the one-on-one teaching, the going over every single case, we have to adapt. I mean, we can't go down with the ship. We have to keep turning out radiologists and training them. And if that means learning how to teach them faster or more more focused in smaller bites in order to get the clinical work done and to teach them this is what we have to do. And I think sharing of resources, getting together with other residency programs. I'm in discussion with another program to talk about oral board prep, between using both the programs, educators to do that, to spread out those resources. And I think we just have to be creative. And while it's daunting and there's a lot of change, it's the next step. And so we just have to work the problem, and using our resources smartly, I think, is the way to go.
Dr. Duszak, as chair, do you have any thoughts regarding that?
Yeah, a couple of thoughts. So number one, thanks, Charlotte, for, kudos to your boss are always good, right? It's not going to get you any points though. But it is been a priority for me, and I know a lot of other leaders as well, is, our departments, I can only be as successful as a department chair as all my team is in their individual capacities. And if people aren't rewarded, if they aren't supported, then they're not going to be at their best. And so, it is something where those of us who support these things really have to do a lot of advocacy behind the scenes, make sure that we can be as creative as we can with our faculty practice plan. Make sure that, for example, the ACGME says you get 50, you have to be 50% to be a program director. And it's not, oh, well, it's 50%, wink, wink, but get over there and read your work list. No, it's 50%. And we have to figure out a way to do that. And sorry, we're not going to, basically commit, GME fraud to do that. Also, as well as, rewarding on the compensation, a number of compensation plans that are out there that have differential reimbursement now for your academic time versus your clinical time. And, our plan was one of those, but within the chair's discretion was to be able to say, okay, we can use some of those discretionary dollars to say, we're going to make Dr. Taylor whole in her role, or our vice chair for clinical operations whole in his role, because who's going to want to do these things if we're saying, oh, we want you to do not only this potentially thankless job, and hopefully you do get some thank yous, but to do it and take a pay cut? Seriously? Who would want to do that? But it is really, it's mission critical for us. And I think we do need to be creative, that this old sort of academic cash cow methodology that, nobody really had accountability for dollars. We were the dinosaurs of what healthcare looks like across the nation. And I'm not saying we need to turn into a for-profit entity, but we start needing to do some of the things that Dr. Taylor's talking about doing, leveraging economies of scale. We don't need a whole bunch of general carpenters. We get somebody who's the expert plumber, the expert electrician, and we let them do their things at scale. And so, sometimes these belt tightening exercises do force us into innovation. I'm not saying it's necessarily better, it's necessarily worse, but it's reality. It's what you got to do to adapt.
Yeah. And I'm so interested, Dr. Wheeler. I mean, you have trained through these kind of rapid changes that are happening in healthcare. I mean, and I don't mean to make you feel uncomfortable or anything like that, but have you seen, just from when you were a first year resident to now a fellow, changes in the way you check? I mean, obviously COVID played a role in how we, check out and things like that. But I mean, have you seen there have been differences now with how you were trained at the beginning of your training to now? And if you could comment on those.
Yeah, I do think, part of it is just growing autonomy as you're, graduating up as well. But there is a degree of, self-directed learning, at all times, and you just learn to adapt with the demands of clinical volume. And so I think really one great thing that I've enjoyed benefiting from in the last couple of years too, is just seeing how, like Dr. Taylor was saying, attendings are getting creative and trying to really, squeeze in as much kind of bite-sized learning as you can. And something we do in the pediatric neuroradiology section here at Emory and Children's of Atlanta is, we just do a 30-minute little kind of mini lesson every day. And it's great because, we're all connected digitally. We're on Microsoft Teams. So all the residents and fellows on the rotation can come together very quickly jump on. It's at the same time every day. And it really is just a very kind of digestible and also hopefully fairly painless for the attendings as well, because, someone is kind of remotely also, able to kind of watch the list and handle any, questions that come along from the text or otherwise. And then, that other attending who's kind of dedicated to teaching for the day can just spend that time and really focus for 30 minutes. Everyone feels like they've kind of got their investment for the day. Maybe it's a little challenging for a junior resident. Maybe it's a bit of a review for a fellow, but at the end of the day, it's actually really helpful. And it feels like you've covered a topic. And then by the end of the week, you've added up that time, and you've also covered a range of content. And so I think things like that, where you can just put a drop in the bucket and kind of stack up small wins, is really, really helpful.
Dr. Taylor Duszak, are you doing something kind of similarly? Or there is some, I know, Charlotte, you had mentioned some sort of, bite-sized kind of learning or teaching, but anything similar to what Austin's talking about?
I think some of our sections do have embedded case conferences. So instead of everybody tuning in at noon just for, well, they do that every day, but in addition, they'll have a morning conference or an afternoon conference. Well, they have one attending whose job it is to do the teaching, and then everyone else reads off the list during that time. And I think allocating one person to be the teaching, attending, or educator, even for the day or for the hour or for 30 minutes while everyone else works on the list, will reduce the anxiety associated with having the whole section get together and just watch the list pile up as we teach. And I think that's a smart way to do it. It's a resource allocation that's feasible even for a busy small group. But you have to be intentional about it. Another thing that I will add to Austin's comments is that the asynchronous content that is available since COVID has just exploded. And these are some of the best educators in our field who have free open access YouTube channels, who have through our societies, the educational content through the societies, most of which are free to our trainees or at a significantly discounted rate. We can use those resources to flip the classroom. We do a good amount of case conferences as oral boards are coming back. We encourage our faculty to give case conferences, and we have a dedicated video curriculum that has a video and an article assigned for each rotation. And it's an Excel sheet that I made. I mean, it's not high level stuff. It's just an Excel sheet with links to articles, and the residents are expected to watch those on their own time. And then the faculty are more free to not have to cover a dedicated didactic curriculum, but they can give case conferences and do the real radiology teaching, the things you can't replace with a YouTube video. And that's how do you take a case? How do you approach it? Here's my search pattern. All of those things that you get from a in-person or at least live case conference do not need to be replaced with something asynchronously. So just shuffling things around of what we were already doing can be completely feasible, even for a low resource institution, a lower resource community practice that doesn't have, a bunch of radiologists teaching.
A question I have too is, are there some certain practices or things that maybe you started implementing during COVID that you thought, this is working pretty well, and it's helping with, efficiency and with impactful teaching? Are there any pearls that you could share with those who are tuning in?
I think one thing that we really leaned into during COVID was the resident teaching. Upper level residents, utilizing upper level residents to teach lower level residents. We had a greater reliance on remote radiologists, and this was our own radiologists who were reading remotely to spread everybody out when we didn't know how bad COVID would be, or when it was very bad and we had our surges. We had home workstations became the norm. And even though the daytime remote reading is I think is less ideal for teaching, especially for the lower levels, the R1s, and anyone starting on a new rotation. It actually gave our residents more autonomy when they needed it. When they were on call, they were the one, instead of the surgeons walking into the reading room and going straight to the attending, they had to talk to the resident first. The attending is there, the attending is available, but beforehand, it was so easy for them to skip that, and they lost that experience. And that was now available to them. And I think that really improved our residency training program, just because they had to make the decisions on their own to some degree before asking the attending for help. So I really enjoyed seeing how much autonomy it gave our residents.
Is there something, Austin, that you maybe have found during your training in that period that you felt like, this works better for us than something else?
Well, I think also, just speaking to Dr. Taylor's point, I wanted to mention as well, I think that the clinician educator pathway specifically is just a great way to capitalize on exactly what she's talking about, really kind of mobilizing even just trainees as teachers, because I've seen that, over the years. I've seen that in residency at UAB, really, Dr. Desiree Morgan and now Kaz Bergen were really, instrumental in spearheading that in residency. And then I've seen, Dr. Mullins, Mark Mullins, and Brian Peterson at Emory, who are also kind of national leaders in that space as well. And it really, builds so much momentum. And now there's so much interest and engagement among the residents. And so just like Dr. Taylor was saying, you have really, a robust amount of opportunity now to have a senior residents teaching junior residents, and junior residents reaching out to local medical students. And it just builds, because then it also becomes, a recruitment exercise in the radiology pipeline. And so I think that has been huge, and I've really enjoyed that. I was a part of that in residency. And I think it also is such a kind of triple win and a triple hitter, because they're teaching, so they're also learning and reviewing concepts and solidifying things. And then, like I said, it also becomes a recruitment piece. So I think that, and then, also, I think just, again, really clarifying roles, which is something that we talked about, a lot already. And in the article is just defining who is kind of the teacher for the day, like Dr. Taylor said. And that way, the trainees kind of know who they're working with for the day, and then the attending kind of knows that role. And so doing as much as we can just to support that initiative, I think, is huge.
Anything else you'd like to add, Rich?
I'm going to jump on to the bandwagon of getting trainees to be teachers. That has not traditionally been, I mean, there's been some pockets of that, but that's not traditionally been the culture within radiology, whereas in a lot of other specialties it has. I mean, I did a rotating internship, and I remember, I learned a lot of, OB-GYN stuff from the chief resident or the junior resident or the intern, and surgery and stuff like that. And I think there's massive opportunities to lean into that. I was just talking with one of my friends from residency at a meeting at the ACR Radiology Leadership Institute Summit, Rob Optikin, and we were talking about John McKenzie, who was a resident 2 years ahead of me. Just name, I'll give him a shout out if he's listening as well. But I learned John used to be a neurologist before he was a radiologist, a radiology resident, and I learned more about neuroradiology when I was a resident from John than from anybody else, because he was always like the guy who was teaching on service. And so it really warmed my heart. I love to call a shout out for people, as Charlotte knows. Baylor Obert's one of our interventional radiology residents. I was an IR. He's at the workstation next to me. We had 3 medical students on service, and he was teaching them stuff, and he was even talking to the dermatology 4th-year resident who's rotating through. Well, when we're doing cases, we're going to show you how to really do lidocaine well. That'll be important to you. I mean, everything is a teaching opportunity, and great teachers have said you don't really become a great teacher, really understand material until you've taught it, because you have to challenge yourself through these things. So I think there's a huge opportunity. That was one of the threads that Austin and Charlotte jumped into in our article, and that's something where I've learned from them. Like, wow, I sort of knew this, but we need to be doing this for sure.
That's great. And I hope that other, institutions follow suit. And, I hope that learners look at it as a really awesome opportunity and not as, because I could see some maybe saying like, oh, they just want to teach, is getting dumped on us. But really, I think it's an incredible opportunity and really can help reinforce the material. And I think that, I was fortunate to do my residency years ago at the University of Kansas in Wichita, and there was a lot of senior level resident teaching and also collaborating with our attendings. I remember my senior year, I put together a first year radiology like quiz curriculum with my program director, and I learned so much just from putting those questions together and that material getting reinforced. So I think that is such a great avenue, and just a gem of a skill to have for each residency program. So that's wonderful. So I want to transition now to this question's for Dr. Duszak, for Rich. How do we continue to strive to educate and to advocate for our learners when attendings have just so much pressure, like we talked about already, to produce, and regardless whether it's a pure academic model or a hybrid model, or maybe there's a private practice group affiliated with the residency program, which is what I had, or the residency program that I did. And, how are chairs, are you talking to chairs, and are you about like, how are their departments sort of handling this, and just the pressures that are coming with the turnaround times and the volumes? And I'd love to get your thoughts.
Yeah, I wish I had a definitive answer to this. I don't. But I think, how do you approach this is important. An institution is only going to allow people to perform to the level where the institution supports it as well. And, if the residency program director or the vice chair for education says, teaching's not really that important, just go read studies, then it's never going to be important. And even if she says that and the chair says it's not really important, it still never translates out because of incentives, because of priorities, all these other things. And the same thing, I joke around, I'm middle management. People are like, oh, the chairs can do everything. No, we're middle management in this. So, we've got to be working together to get that message out there that, while everybody's pushing the high priced consultants in their, Gucci suits are coming in saying, oh, RDU comp models and things like this. We, as doctors, as educators, as academic physicians, need to be pushing back and say, what about this other mission? We're just going to completely ignore this. And it's not easy to challenge those types of folks, but somebody's got to do it. It's our job to do that. But I think also thinking creatively at the leadership level among peers. So there's a lot of conversations like this that go on with SCAR, the Society of Chairs and Academic Radiology Departments, where, it's a lot more sort of networking from a point of view of sharing ideas. But even within our Council of Clinical Chairs, we talk about in our sessions all the time, we're being asked to generate these RVU productivity. How are we going to do this? How do we carve out safe space for this? How do we carve out dollars to continue to support these? And so the conversations have to be there. One person cannot do this alone. It's got to be done through coalitions that basically get the message out there, because it's really got to be a culture at the institutional level. And that's what I'd encourage people to fight for, is to help create that culture rather than try to go it alone, because you can't fix it alone.
What advice would you give? I'm just curious, like, let's say there's a new chair or a struggling chair out there is trying to achieve this kind of buy-in and culture. Do you have any tips on how to achieve that?
Yeah, it depends upon the circumstances, of course. Everybody you say struggling chair, every chair is struggling right now. Academics is just so different than it used to be, given all the incentives and the priorities and things like that we're trying to corral at the same time. I will tell people, number one, you're not alone. If you feel like you're struggling in an issue, find a peer, find a mentor. And, I built a army of my own peer mentors where we call each other all the time, and sometimes it's just well, we're being recorded. It's to vent. I was going to say something more inappropriate than that. And it's to vent and it's to listen. And sometimes it's to get advice. And that's bi-directional. It's not like there's one person. Well, we always call her for advice because she has all the answers. Yeah, no, she calls me too. And it works that way. So I think that's got to be part of it, is that recognizing you're not alone, share ideas. But also figure out ways to navigate the system. And again, it's, find people even within your own system. Sometimes you have to reach out for advice out of the system, but people within your own systems. And there are people who, as an individual chair, as an individual associate dean, may not be willing to be at the tip of the spear themselves, but would be willing to be part of a coalition to start bringing things forth to the dean or the CEO or whatever your system is, to say this is a gap, and also potentially bring them solutions. Bringing people in leadership problems, particularly if it turns into a complaint session, is usually not effective. But if you can get some smart people together to say, hey, we'd love to pilot this, will you support us? That goes over very differently, and you're really asking the same thing.
Has there been any discussion amongst like SCARD or APDR to maybe, a lot of times organized radiological societies can be very helpful when it comes to tackling issues. Has there been any discussion of possibly having some sort of coalition or effort to tackle some of these issues?
The APDR has been working towards creating more shared resources to support programs. I was part of an initiative through the education committee to create standardized rotation guides, which include things like links to must-see cases, links to videos, to help support programs, especially new program directors, or if you're overhauling your curriculum, to support them in those efforts. And that's just the tip of the iceberg of what the APDR is doing. So having more shared resources to reduce the burden on programs, I think it is a major mission. And going forward, that's what we're working on.
Yeah, that's wonderful to hear. Anything from the SCARD standpoint, Rich?
Lots of idea sharing is going on, but I think some of this even goes higher. I mean, what we're talking about in radiology, because this is the Journal of the American College of Radiology, these are not unique to us. These are across all of academic medicine. So there's a lot of similar discussions. I mean, I'm not a regular attendee, but I've previously attended AAMC, Association of American Medical Colleges, and at the associate dean and deanless level, they're talking about the same things. It's not like, oh, it's woe is us radiologists and our deans don't care. Everybody really, I mean, people don't go into academics, certainly not for the money. Everybody is sort of working on this separately. So there is a lot of support there, and I think that's good as well, because if you can get your dean together with another dean, and again, back to the system, is that, I can only get my system so far. Well, that's sort of where you're stuck. Now, I'm fortunate, my boss, our dean, was chair of the Council of Deans of the AAMC a couple years ago, so very well connected. And that's also helpful that, you have people at multiple levels, whether it's the residents going off to the chief residence meetings, the program directors, the chairs at SCARD, or the deans. Everybody is sort of horizontally communicating with people at other institutions. And I think that's how you get the ideas. You have to create a culture of wanting to share ideas and then bring them back. And every place has got its own culture, and then you have to figure out how to implement that in your place.
So I'm going off the script. So a question sort of came into my head, and I'm going to go there. So a provocative question. So, if you don't feel comfortable answering, that's okay. But it is a question that I have on my mind often as healthcare is evolving, and to speak to the subject of consolidation. Is there ever a concern, and maybe, I ask you, Rich, because you've seen the spectrum of, I don't mean to like age you, but you come as a seasoned expert. Do you ever feel that the degree of education, that there could be inequities in educating our learners based on whether they are training at a for-profit organization or a nonprofit organization, or affiliated with, I'm going to throw it out there, private equity practice? Or do you think that the issues are pervasive just across the board?
Yeah, I think there are disparities, differences, inequities, whatever term you want to use, in education across institutions. But I don't think this is anything new. I mean, I applied for radiology residence. I graduated medical school in 1989. I was, interviewing for radiology residencies in 1988, and there were programs where it was very clear, like, yeah, this is a safety program. I really don't want to be here, but okay, I do want to be a radiologist. And those things change. I mean, I won't call it out, but one institution where it's like, it's a really good location. I'm like, okay, if, I have to match somewhere, it's not going to be the best training, but be a really nice place to live. And that's a great program now. So these things do cycle back through. And I don't think, at that point, there was no private equity and all these other things. So, a lot of it is, I think, who the leadership is at the very high level of the institution. What's their financial situation? If they're financially squeezed, they're not going to have resources to do types of things. What are the priorities of the institution? So you've got the CEO, you've got the dean, you've got the chair, you've got all that, and that could be a scramble. Now, those things, I think right now, because there are a little bit more stereotypes, if you will, of a for-profit versus a not-for-profit, of a private equity-based organization for not. So you may get sort of a little bit more merging, if you will, of the cast of characters, of their phenotypes, of those places. But there are some places. I mean, I know a lot of people push back, and all private equity is evil, and I think there's a lot of good data that says it does really bad things to patients, prices and costs and things like that. But there's some really good radiologists who work in those organizations who are really good educators, and they're really committed to the education. So I don't think we want to paint too broadly with broad brushes, with our paintbrushes there with that. But yeah, as a general rule, it's got to be one of your core principles. It's got to be something core to say education is us. We are education. Those institutions, by and large, are probably going to do a better job educating.
Anything you'd like to add, Charlotte or Austin?
I think, in terms of this being isolated to a certain type of institution, I really think that it's pervasive across all institutions, particularly in the area of the clinical volumes going up. I think that's the number one thing people want to talk about in the education meetings that I go to is, how do you manage education? How do you manage the academic mission with the rising clinical volumes? And that's regardless of how you came to that point, that's the end point. And that's where it all comes down to is, you can't pull time from another dimension. And if you don't have time allocated for education, it won't happen. So I think while we're in different institutions, maybe different practice settings, I do think that this issue is common to all education programs across the country.
Yeah, and I think, you realize on a macro level, you're looking at, how are we going to try to play to our strengths among institutions, departments? We're also just trying to do that on the micro level day to day. And it's really the same philosophy. It's a big Tetris puzzle. We're trying to, again, understand that maybe from day to day, an educator does want to be the assigned teacher for the day, a couple days a week, maybe one day would prefer to be kind of, whittling away at the list and focusing more on clinical volume. And so people are playing to their strengths, but also I think each of us, given the day of the week, may have a different preference. And so again, kind of going back to the idea of a Tetris puzzle, we're really just trying to, adapt and be flexible about what the demands are for both trainees and attendings. And I think that way we can really succeed if we don't just try that kind of one size fits all for every department across the country, every attending, in the section and so forth.
Yeah, I think that's incredibly good advice and very wise beyond your years of, being that you're a fellow, but man, you really I feel like you are sharing some really incredible insights. You're going to be a great attending radiologist. So let's see. I want to see if we have any questions because we are getting close to the top of the hour. Any questions in the comments or on X? Let's see. Don't see any questions here. Abby will let me know if we end up having questions on X. Let's see. I don't think we have any so far. So I guess, today I feel like we've had a really, really great comprehensive discussion. And I hope that many will, who possibly haven't read your piece yet, will go and look, and those who have as well, garner some really good tips that they can implement at their residency program. So I guess, to wrap things up for the evening, what's one sort of main takeaway that each of you would like to share in regards to this subject? So we can start with Austin.
Oh gosh, give me a minute to think about it. I'll go. How about I'll go next or last?
Okay, either Charlotte or Rich, you can go.
I'll go. I think the main thing to take away from our paper and from our discussion is that we have to be intentional about education. It's not easy to make time to do this, but it is important, and it is important for the future of the specialty. It is important for the future of your own department, because your trainees are your best recruiting pool for most departments. We know these trainees, we know how they work and who they are, and how they get along with others, and we know how much they know and how much they need to learn. And if we don't prioritize education, then we will also not be able to recruit into our own department. So very important.
All right, I've got mine. You ready? Well, thanks, Dr. Taylor. I think that really kind of sparked something in my mind. So really, over the years, I think something that just continues to be solidified, and this is true for every physician, it is continuing medical education that at the end of the day is on you. I think that the onus is on you. It is a self-responsibility, and the buck really stops with you, that you're learning your foundation of knowledge, your habits, the way that you practice and the way that you develop thought processes. That's all, when you go home after work, after the investment in you, education, clinically, all of it, that's ultimately up to the trainee and up to you as an attending when you get out of training too. I don't think that ever stops. And so, realizing that, yes, we do need to be very appreciative of the investment being made in us. Residency programs, fellowship programs are working extremely hard to put out good radiologists. But if you want to really be an excellent doctor for your patients throughout a career, realizing that starts now, and that starts, from day one of medical school, day one of residency, and day one of fellowship. And so, yes, there may be some varying degrees of strength educationally, depending on where you are, but really, that should just mean that you're putting that much more in to fill those gaps too. And so that's something that I've realized, is going to be true even, in a couple months when I get out. I'm not done learning, and I haven't covered everything I need to know, but that's part of why I went into medicine. I love to learn, and I want to, continue to dive deeper into my field. And so I think that's just something we can all take away from a talk and an article like this.
And Rich?
If you go back to the days of Hippocrates, it's buried somewhere in the Hippocratic Oath, something about one of our things is to, train the next generation, to share our wisdom and do those types of things. Our healthcare system only continues to exist, only continues to improve if those of us who are practicing today make a commitment to help train the next generation. Otherwise, it all falls apart. All that knowledge gets lost. So, we've got to prioritize education, because if we don't intentionally, to use Charlotte's term, intentionality, if we don't prioritize education, education will never be a priority. And then, yeah, we're not going to see the whole system fall apart tomorrow, but we will see it fall apart over the next generation. And so we've got to figure out a way to do that. And this can't be a burden that's borne by all of the individual people out there. Yes, everybody needs to grab a shovel and glove, get in the game, whatever analogy you want there. But we do need to challenge our leaders. We need to challenge our health systems. We need to challenge our policymakers to be able to say, is this important? Do you want your legacy, Mr. Congressman or Madam Senator, to be basically you're the person that killed the next generation of healthcare? So this has got to be fought on multiple levels. I don't think it's a partisan issue. I think, there may be differences in how we do it. But unless we make it a priority, it won't be a priority, and the future won't be as good as the future that we inherited.
Yeah, I think you make a great point. It really is going to take all of us to ensure that we're able to adequately educate the next generation and just continue to build on our efforts. And really, and it's my background as well. Policy is incredibly important, and we're definitely pushing as much as we can through the American College of Radiology on the policy side, as you know. So you said it very well, very well. So thank you all tonight for just your expertise, your wisdom, for writing just a really incredible piece, very novel. I found it very refreshing and very different from other opinion pieces that have been published. And you went there and you brought solutions to the table. And so I think this is going to be a benefit to many who read it and who have already read it. So with that, I thank you all. I'll give you a few minutes back of your time this evening. And thank you to those who are tuning in. And we'll see you at the next Journal Club. Thank you so much.
Thank you, Amy.
Thanks.
Thanks, y'all.